Okay, so heart scans and maybe, scans for cancer and neurodegenerative conditions.
I think that when people look at heart scanning, a lot of people put a lot of weight into just getting what's called a coronary calcium score. And what I really want to emphasize to people is this is not a very useful number. Now, obviously, if you have a very high coronary calcium score, it means you probably have other things going on. But in general, calcified plaque is not dangerous plaque. It can build up enough that it creates stenosis or narrowing of an artery, but that's really slow. But in general, think about calcified plaque, that calcium score, that hard plaque is cement. It is in the blood vessel. It's not going to move. What kills people, those sudden cardiac deaths, is soft plaque. So this is a fatty plaque that is very vulnerable to rupture, travel down the artery, and that's what causes most people to drop dead of a heart attack who were just walking down the street or playing golf. So how do we find soft plaque? And that's where we need now more some of the newer technologies. Now, again, if you have a high coronary calcium score, it means you probably have soft plaque too, but not always. Sometimes people had, they had soft plaque, it calcified, their calcium score is high. And then when you get scans, you see that they have no soft plaque, they're doing well. So what we like to do is use a coronary cardiac scan. So coronary what's called CCTA, coronary angiography. And then now there's technology that AI can look at that and it can gauge the type of plaque and how vulnerable that plaque is to actually rupture and cause problems. So we can actually tell how much fat is in that plaque and dictate whether somebody has vulnerable plaque that I need to really be concerned about. When I treat soft plaque, what I want to do is calcify it. So I actually want to increase that coronary calcium score. I want to make it cement. I don't want it vulnerable anymore. So I want to turn that soft fatty plaque into hard calcified plaque. So again, that's where these calcium scores are misleading because sometimes they're looking at somebody who has they're really at a very low risk state, and the doctor told them they need surgery because their calcium score is high. So basically, we have to look at now some of the newer technologies. Clearly is one, and there's now a very new technology not yet available to most people that actually is looking at inflammatory changes in the blood vessel, because we also know that inflammation in the blood vessel is the first precursor. We need to be finding that. So we need to be looking at that before it even turns to plaque and treating those people as well. We're seeing that a lot now in our sort of post-viral world of people who have inflammatory changes to the blood vessels that we need to address much earlier than the plaque even begins. And then once you see the plaque on there, there's lots of treatments you can do to help eliminate the plaque or calcify the plaque, like colchicine. So there's lots of things that we can do that actually, so it's not like this is a death sentence. There's tons of things we can do as long as we know it's there. So I think everybody really thinks needs to be doing, once you get to be a certain age, probably at least 50, I would say, and again, so it depends on your family history, what some of your other numbers are. If your C-reactive protein's high and your lipids are horrible and you have high Lp(a), probably even younger, you should be doing a clearly scan. And now that's much more available to everybody, and oftentimes even paid for by insurance, at least here in the U.S. So that's a great test. As far as cancer screening, we now have all these blood tests to screen for cancer, right? There's a few of them on the market. I prefer what's called the Gallery scan. And it's basically a blood test that looks for not circulating tumor cells, but methylation changes that will dictate or predict cancer risk. Now, it's not good for a couple of kinds of cancers. It's not good for prostate. It's not good for breast. But it's got very good sensitivity for a lot of the cancers we aren't good at finding, like pancreas, like stomach, like lung. Those usually don't get found until they're metastasized. This can actually find them at very early stages. So I actually like that test. It will find a cancer before, like the pre-nuvo, the total body imaging will. For total body imaging to show a tumor, it has to get to be a certain size. Oftentimes that's a pretty big tumor to see it on the MRI scan imaging. So the Gallery scan is something that we do yearly on our patients to look for these markers that tell us we need to be searching something out. And it's got very good sensitivity and very good, if it's positive, you likely have cancer. The tricky thing is sometimes it's hard to find the cancer. Like it'll tell you it's lung, but you'll go do a scan maybe and you don't even see it yet on the scan because it's so small. So that becomes a little bit of, what do you do at those stages? But at least I can be very, very wary of following that patient super closely until I can see something. So it's great for colon, it's great for stomach, it's great for lung, it's great for pancreas. So I think that's a really useful test to people. It's expensive. So it is out of the reach for a lot of people. Just like the Prenuvo, the total body MRI scanning. Those are nice, but they're out of reach for a lot of people.